Hello, everyone, again, and welcome to Strategies to Maximize Clients' Effective Use of FDA-Approved Pharmacotherapy. Our presenter today is Dr. Christine Garver-Apgar, BHWP's Research Director. Dr. Garver-Apgar earned her doctorate in experimental psychology from the University of New Mexico in 2008, and subsequently completed a postdoctoral fellowship at the University of Colorado at Boulder's Institute for Behavioral Genetics in 2011. She then served as the senior statistician for a research group within the Department of Psychiatry here at the Anschutz Medical School until 2014. As research director for BHWP, she develops, implements, and oversees several programs, both for us as well as our partner agencies. Thank you all very much, and I hope you enjoy today's presentation. Christine?
Thanks so much, Jim. I just started sharing my screen, so hopefully everybody's seeing the title slide now of this presentation. As Jim mentioned, I'm Christine, and I'm the Research and Evaluation Director here at the Behavioral Health and Wellness Program. I'm so excited to be presenting this information to you today on tobacco cessation pharmacotherapy. This is a webinar about medication-assisted therapy, but I'm not going to spend a whole lot of time introducing all the specific tobacco cessation medications in great detail. Instead, I'm going to try to move beyond basic knowledge of tobacco cessation medications and discuss how to really maximize pharmacotherapy's effectiveness. If you do need that basic information, however, about all of the FDA-approved pharmacotherapies for tobacco cessation, I want to give you this link. You can visit this link. This goes to a video of another webinar that I conducted. And some of the information overlaps with what I'm presenting today, but much of it offers more of an introduction to pharmacotherapy. So if you find that you do need that information, then I encourage you to visit this link. Okay, so this is the agenda for this hour. In the first section, I'll describe critical things that both clinicians and clients should know about nicotine addiction, cravings, and withdrawal in order to maximize their use of tobacco cessation medications. And then in the second part of today's webinar, I'll discuss ways that clinicians can better prepare their clients to make a quit attempt with the help of cessation medications through education and discussions about assessment and proper dosing, how to use medications and strategies to increase medication adherence. And also I'll provide a little information about preventing relapse, but also addressing it when it occurs. Okay, we'll start out by talking just a little bit about nicotine addiction and why cessation medications are helpful. Because sometimes our clients aren't really thinking about the physical addiction. And having this discussion with some clients can be a really powerful way to dispel the myth of simply having enough willpower to quit, as if that's something lacking in someone who hasn't yet had success quitting tobacco. It's also important that clients understand nicotine addiction so that they can develop proper expectations about what tobacco cessation medications will and will not help with, and why medications themselves are not addictive. Individuals with addictions to other substances like alcohol, heroin, or cocaine will very often report that tobacco was the most difficult addiction for them to overcome. So it's no surprise that more people who try nicotine become daily users than people who try other drugs. So why is it that nicotine is such an addictive drug? Part of the reason is that tobacco companies have spent many, many decades now perfecting how to get nicotine to the brain as fast as possible. Because the faster it gets there, the faster an individual experiences behavioral reinforcement for smoking, and the more addictive it becomes. So each cigarette delivers about 1 to 2 milligrams of nicotine, and that will be important to know when we talk about dosing nicotine replacement therapy in just a little bit. And after a person takes a puff from a cigarette, nicotine from that inhalation will reach the brain within 10 seconds. If you administered nicotine intravenously, it would not reach the brain that fast. So it's really, really quick. And because it reaches the brain so fast, smokers can really easily control how much nicotine they're getting. And that makes cigarette smoking more reinforcing than nicotine obtained in really any other way. And that's also why nicotine from other sources, like the nicotine patch and the gum, have so much lower potential for abuse.
Can you stop sharing and reshare your screen? They're only seeing me.
Oh, I'm sorry. I just was told that nobody is seeing my slides. That's so sad. Let me stop sharing. And I'm going to try resharing. Let's see if that did anything. Jim, does this look any better?
I don't know that you can hear me, but yes.
Okay, well, I'm so sorry about that. I know we're going to send out slides after, so you really only missed 2 or 3 slides. And you were listening to me, so I'm not going to go back and recap, but we'll just move along. At least you can see what I'm seeing now, so that's an improvement. Sorry, everyone. Okay, so this slide summarizes abstinence rates for different treatment strategies, starting with no treatment at all. So clinicians can help clients understand that unaided quit attempts are often not particularly successful. And this doesn't indicate a problem with willpower for the reasons that we've been talking about. While all of these techniques are effective compared to no treatment at all, you can see that a much higher percentage of people who receive medication and counseling together are able to quit using tobacco. And clients should understand that the reason counseling and medication together are the most effective at treating tobacco dependence is because tobacco dependence has 2 parts. Pharmacotherapy addresses the first part of tobacco dependence, which is the physical addiction to nicotine, whereas counseling addresses the second part of tobacco dependence, or the habit or the behaviors surrounding tobacco use. So it's really important for clients to have realistic expectations about how tobacco medications are likely to help. They help with physical craving for nicotine, but they don't replace counseling to change behavioral habits. Oops. Okay. This slide lists the 7 medications approved by the FDA for smoking cessation. 5 of these contain nicotine, and they're called nicotine replacement therapies, or NRT, and 2 of them do not contain nicotine. 3 of the NRT medications are available without a prescription. That's the nicotine patch, the gum, and the lozenge. Whereas the remaining 2 NRT, well, all of the remaining medications require a prescription, including the nicotine nasal spray and the nicotine inhaler. So as I mentioned, I'm not going to go into great detail about each of these medications. They are all effective, as you'll see on the next slide. And so really the best one to use is the ones to use is the ones that patients will use as they've been directed. Okay, so a little bit about the efficacy of these medications. These data were taken from the United States Preventative Services Task Force updated its 2009 recommendations for tobacco cessation, and a very large review of clinical trials looking at the efficacy of both behavioral and pharmacological interventions was conducted. And so this chart reviews results from several different meta-analyses in which data from lots of studies are pooled together for analysis. So NRT, bupropion, and varenicline improve the chances of smoking cessation at 6 months follow-up or longer compared to a placebo. NRT and bupropion increase the likelihood that a person will be abstinent from tobacco at 6 months post-quit by about 60%. That's what the numbers in red are indicating. And then varenicline more than doubles the likelihood of abstinence at 6 months compared to a placebo. And then this slide provides just a snapshot of quit rates maintained over a 36-month or a 3-year period across all of the FDA-approved medications. And the take-home message here is simply that the quit rates for individuals who use some form of cessation medication, no matter which one they use, are higher than for those individuals who used a placebo. So again, really the best medication is the one that clients would like to use. All right, so I want to talk just a little bit now about nicotine addiction, just a little bit more. Nicotine addiction is no different from any other addiction. People use addictive substances because there are rewards from using them. And today, we're really talking about the biological rewards, things like feelings of arousal and pleasure. All drug addictions involve physical dependence. And what that means is experiencing both tolerance to a drug and also withdrawal. As tobacco users become increasingly tolerant, they have to increase the nicotine use, either just to get the same biological rewards or to simply avoid symptoms of withdrawal. And that leads to ever greater addiction. We'll talk a little bit more about withdrawal effects. When people stop using tobacco products, and depending on their level of use, they will very likely experience some or all of the symptoms mentioned here. And usually they will experience a strong desire or a craving for tobacco. They can also experience symptoms of depression because taking away nicotine has the effect of reducing dopamine and serotonin activity in the brain. So in general, withdrawal symptoms appear within the first 1 to 2 days. They peak within the first week, and then they gradually dissipate over the next 2 to 4 weeks. Cravings and urges for cigarettes, though, can take much longer, even months or years, to go away after quitting. So cessation counseling helps to address the behaviors or the habits surrounding tobacco use. But when someone is experiencing symptoms of physical withdrawal, counseling is not particularly effective, which is why pharmacotherapy in combination with counseling can be so helpful. Cessation medications work by helping to alleviate nicotine withdrawal so that people can focus on working to change their smoking behavior. And that's really an important message for clients, that the medication can be really helpful, but it really isn't often the entire solution. Okay, I want to talk a little bit just about what a day across the nicotine addiction cycle looks like for most smokers. What this graph is showing, this depicts a typical nicotine addiction cycle here from 8 a.m. to in the middle of the night, 4 a.m. And what you see here is the jagged line, this little zigzaggy line, represents the venous plasma concentrations of nicotine as a cigarette is smoked every 40 minutes from 8 a.m. to 9 p.m. and then all the way it shows through to overnight. The upper solid line indicates the threshold concentration for nicotine to produce a pleasurable or aroused sort of feeling. The lower solid line indicates the concentration at which symptoms of abstinence or those sort of negative, unpleasant withdrawal symptoms start occurring. And then the shaded area in the middle, that represents the zone of nicotine concentrations where the smoker is comfortable. They're not particularly aroused or experiencing pleasure, but they're also not experiencing any symptoms of withdrawal. So they're just comfortable in that range. And what I want you to notice about this figure is that the arousal or the pleasure that people experience, so anywhere over the curve, after smoking that first cigarette of the day. If you look down at 8 a.m., nowhere else on this addiction curve do you see a jagged line go so high above that comfort zone and into the pleasure zone. This is why many smokers will say that their most important cigarette is the first one of the day. And how quickly someone smokes that first cigarette of the day is a strong indicator of tobacco dependence. The reason the first cigarette is the most pleasurable one is because tolerance starts to develop shortly after that first cigarette. And as smokers become more tolerant to nicotine throughout the day, they get less and less pleasure out of each cigarette. Instead, they're simply getting relief from nicotine withdrawal. Overnight, a smoker becomes resensitized to nicotine, and then the cycle starts all over again the next day. The figure also explains why you commonly hear in trainings, including this one, that one common recommendation is to take a gum or a lozenge immediately upon waking to boost that steady nicotine being offered in the patch. However, the medication does take 15 to 20 minutes to work, so clients won't necessarily experience an immediate sense of relief with that strategy. So it's really important that they realize this. Okay, I'm being told we need to stop and reshare the presentation again. Sorry about this. Okay, let's see if that helped. Jim, can you see this nicotine addiction cycle?
I've never had a problem seeing the slides.
Oh, I see.
One of the people who couldn't can now do it. So I think we're good. I think it seems to be affecting people who log in after we've started for some reason.
Oh, I see. Okay, well, sorry about that. That's a weird fluke. Okay, so sorry for people who just missed the nicotine addiction cycle, but I'm going to move on to the next slide. All right, so in this second half of the webinar, I'll continue the theme of how to better prepare clients to make a quit attempt using tobacco cessation medications. I'm going to cover how to administer a validated assessment of nicotine dependence, and also some key tips and tricks that are important to know when using particular medications, so especially NRT. And I'll also talk about strategies to help both clients and clinics with medication adherence, and how to help clients prepare for relapses when and if they happen. All right, so one of the best ways that clinicians and providers can help prepare clients for an effective quit attempt using medications is to get the right dose. And to do this, it's a very good idea to use a validated assessment tool as a starting point for dosing NRT. So the two prescription medications that don't contain nicotine, those have much more regimented, standardized doses. So here I'm only talking about nicotine replacement medications. The Fagerström test for nicotine dependence assesses a person's physical dependence on nicotine. So it's shown here. It has 6 questions. It's been validated for adults. There's also a version for adolescents called the MFTND. The 2 items that you'll see here in the orange rectangle, hopefully if you're seeing the slide, together, oops, there's the orange rectangle, sorry. Together, these 2 items make up the heaviness of smoking index. The reliability of the HSI, the heaviness of smoking index, is comparable to the full measure, although some evidence suggests that if a person is not highly dependent on nicotine, then the full 6-item version is really preferable. Both of these assessments, of course, are short, especially the 2-item version, and they can be adopted into clinical workflows pretty easily without a whole lot of effort. And they're both very easy to score. You just simply add up the points that are shown here. So this chart serves as a rough dosing guide corresponding to the scores on these two assessments. Scores on the full measure range from 0 to 10, with 10 being highly physically dependent on nicotine, and scores on the HSI range from 0 to 6, with 6 being highly dependent. From a clinic management point of view, adopting the Fagerström test, or the heaviness of smoking index, into workflows provides the clinic another way to evaluate whether patients are being delivered quality evidence-based care. So are clients who use tobacco having their dependence assessed? And if they are they being recommended or prescribed the baseline level of NRT that these tools would indicate? So here now, I just want to take a second to provide another link. This links to a quick reference tool that our team has created, which summarizes all of those FDA-approved cessation medications, along with the assessments that I've been talking about, dosages, and dosing schedules. So this is just a nice tool that you have available for you if that would be useful. And I want to make a few other points about nicotine replacement therapy dosage. When a provider talks to a client or patient about dosage, they want to communicate that they've gotten a dosage recommendation from a validated tool. This tool provides a very conservative dosage. And unless the provider has other reasons to expect that the client needs more than this, the recommendations provided here are a good place to start. But clinicians should know that nicotine is really frequently underdosed. And this can be for a whole variety of reasons. For one thing, each cigarette delivers anywhere from 1 to 2 milligrams of nicotine. This is really quite a large range. And so the initial dosage, based in part on how many cigarettes people are smoking per day, it seems to assume the lower level of nicotine absorbed per cigarette. And that's just not true for everyone. So I want to go back and just look at a quick example using these assessment tools, so you can see why sometimes these dosages need to be adjusted. So if you look at just these top 2 questions, let's say a person selects 5 to 30 minutes upon waking for their answer to number 1. That earns them 2 points. And then let's say they smoke 1 entire pack per day, which is 20 cigarettes. And so they would earn 1 point for question number 4. So this gives the person a total score of 3 on that heaviness of smoking index. And as we can see here, a score of 3 on this index corresponds with a low to moderate physical dependence on nicotine. That's the 3rd row down. And a relatively low corresponding dose for the patch. So this would recommend a 14 milligram patch to start. But in this case, a person could really very well be underdosed, especially if they're getting closer to 2 milligrams of nicotine, per cigarette. So this just kind of illustrates why it's a really good starting point, but not necessarily the end of the story. Going back to dosage a little bit, there's also a lot of individual variation in terms of how quickly a person metabolizes nicotine. So that affects physical dependence. And then many people simply underestimate how much they're actually smoking. So for these and other reasons, many people will find that the initial recommendation that they're given is not effective for them. And it's really important that both clinicians and also clients know that it's really difficult to overdose on nicotine. So people who take too much nicotine start feeling really lousy long before they would experience any significant long-term consequences of too much nicotine. So if a client is taking nicotine replacement therapy as they've been directed, and they're still having high levels of cravings, they should not hesitate to either increase the dose themselves or to make another appointment to talk about increasing their dose. All right, so there's several strategies for using FDA-approved cessation medications that both providers and clients themselves should know about. researchers have found that cessation rates are higher when individuals used combination therapy rather than just using one at a time. And in 2008, the clinical practice guideline recommendations were updated to include combination therapy. So the recommendations for combination use are shown here. It is considered safe to use the patch along with any other form of NRT. And it's also considered safe to use bupropion with either the patch, the gum, or the lozenge. Another strategy to increase the efficacy of NRT is to start using it before the quit date. Providers have started using nicotine replacement therapies before an individual makes a quit attempt, and results from studies of this have shown that there are no increased side effects from this practice. And one study at least indicated that using the patch prior to a quit date can double the success rate of that quit attempt compared with using the patch starting on the quit date itself. So that's just something to keep in mind as well. Okay, so which medication is best? We've said the best is the one that clients will adhere to and take as directed. And personal characteristics of clients really determine which medications they're interested in taking. But one common finding in the medication adherence literature is that the more complicated a treatment plan is, the less likely it is to be followed with fidelity. So in general, fewer doses per day is better in terms of medication adherence, if everything else were equal. So for tobacco cessation medications, this would imply that the patch is usually best, followed by varenicline or Chantix, and then bupropion, and then the gum or lozenge. And that's because a traditional gum or lozenge regimen would be for the client to take 12 regularly spaced doses per day, and then, if determined necessary, to be perhaps supplementing with a patch. But 12 regularly scheduled doses is hard to follow with precision. But as I mentioned before, the problem with giving a conservative amount of nicotine through the patch and then supplementing with the gum or lozenge as needed is that the gum or lozenge can take 20 minutes to address that craving, and the client is vulnerable to relapse during that time. So in keeping with the idea of simplifying the medication regimen and moving clients toward treatment plans requiring fewer doses, or if a client is having difficulty managing multiple forms of NRT, a client could consider a higher dose of the patch if they are having lots of cravings. If the client likes the idea of multiple modalities of NRT and they like having something to deal with cravings, they just should know and be aware that those medications don't work immediately. This is, of course, really where counseling comes in. Given that it takes a while to work for the gum and lozenge, you can encourage clients to maybe anticipate times of high cravings and actually take the medication before a craving is likely to begin. So patch application tips, it's generally helpful to provide clients with instructions for how to properly use the patch. Clients routinely don't read the instructions, as none of us ever do, on things we should be reading instructions for. And but really, proper use of this does determine its effectiveness. When it's not applied properly, it has a tendency to fall off. It doesn't withstand water very well. This includes sweating and exercising. Clients should not cut it in half because that eliminates the slow-acting strategy of the medication. It can seep through that cut portion, and then the clients are getting too much too quickly, and then the long-term effects of the patch are negated if they do this. So shouldn't cut it in half. And there are some other tips listed here as well, but just having this conversation with clients is important. And then same with the gum or the lozenge. It's important to have a discussion about using the gum correctly. When it's not used correctly, it can not be absorbed very well in the mouth. More nicotine goes to the stomach than to the bloodstream where it's supposed to be, and that can cause nausea. Increased experience of side effects, if it's not used correctly. And then people should not be drinking and eating food when they are using the gum or the lozenge, especially acidic drinks like coffee and juice, wine. Those things should not be consumed for at least 15 minutes before somebody uses the gum or the lozenge. There are a few other ways to prepare clients for using cessation medications that involve helping them to set expectations and also become engaged agents of their own tobacco cessation goals. So first thing is that many clients have tried NRT before. This won't be their first rodeo for many of the clients that we're working with. They may have received advice or warnings from friends and family members about these medications, even if they haven't tried them themselves. So part of setting expectations may involve exploring with the client what they currently know about NRT and how they came by that knowledge. And in some cases, clients may not have received accurate information. Another discussion to have with some clients is that it is really difficult, as we discussed earlier, to become addicted to NRT, unlike other forms of tobacco, especially cigarettes. So for interested or concerned clients, providers can explain a little bit about why that is, that nicotine from NRT doesn't reach the brain nearly as fast as nicotine through cigarettes, and so it's much less reinforcing. Clients should practice using pharmacotherapy, and some research even suggests that actually sampling different medications improves adherence and cessation. There's also a belief held by both providers and clients that the mode of NRT delivery will be most effective if it matches the client's current mode. So, for example, if a client is using cigarettes, that means using an inhaler. If they are using snuff, then you would replace that with nasal spray. If they are using chew, you would replace that with the gum, etc. But there's really no evidence that this is true. So adjusting from one form of NRT to another really shouldn't affect the efficacy of the medication. In general, just being flexible with patients, experimenting with what works for individuals, and really troubleshooting with clients seems to be important for finding a medication strategy that works and that patients will stick with. And of course, it's also important to acknowledge that allowing clients to experiment for a couple of days or a week with different versions of NRT, that does mean arranging a follow-up with the client so that they can discuss their experience and then determine the best treatment plan. There's one other important thing that both providers and some clients should be prepared for when quitting tobacco. People on psychiatric medications require really special considerations when they quit smoking. This is because the system that metabolizes many of the toxins and carcinogens in cigarette smoke is the same system that processes many psychotropic medications, along with caffeine. And the reason this is important is because tobacco cessation can affect the blood level of many different types of medications, including psychiatric medications. So as tobacco users metabolize and excrete nicotine and other chemicals in cigarettes, they're also more quickly metabolizing their prescribed medications. So what happens is when a person quits smoking, blood levels of many medications can significantly and sometimes dangerously increase. Sometimes side effects of higher dosages of prescribed medications are confused with nicotine withdrawal or psychiatric symptoms. And tobacco use and cessation have the same effect on caffeine. So individuals who smoke and who use a large amount of caffeine might not be able to tolerate those levels of caffeine when they quit smoking. So for example, they may report increased anxiety, for instance, but this could be due to the amounts of caffeine that they're continuing to use and not actually a result of experiencing nicotine withdrawal. So it's important that prescribing providers are aware that their patients are quitting and that they need to monitor medication levels. But it's also important that clients themselves understand these relationships between smoking cessation and their psychiatric medications. So what I've shown here is a list of medications that are known or suspected to have their levels affected by smoking and smoking cessation. And one important note too here, that point I want to make, is that this same thing is not true of nicotine replacement therapies. So it isn't the nicotine metabolism that is causing this to happen. It's all the other stuff in cigarettes that's causing this increased metabolism impact. So when a person is going on and off of nicotine replacement therapy, they don't have the same concerns with other psychiatric medications. All right, another way that providers can help clients set realistic expectations is to discuss lapses and relapses. A lapse here refers to an isolated use of tobacco, whereas relapse refers to a full return to regular tobacco use after a period of abstinence. According to a recent epidemiological study, the risk for relapse during the first 12 months is over 50%. Relapse prevention begins at the very beginning of treatment. It begins at the initial assessment, not just after a relapse occurs. So both initial and follow-up counseling should focus on learning to anticipate and cope with the challenges that often lead to relapse. Counseling should include a variety of components like pharmacotherapy, like we've been talking about, behavioral interventions, and cognitive behavioral treatment. And in particular, clients and providers need to know that if a client has a lapse or a relapse, they should not stop taking cessation medications. They should continue their medications. And this is often something that clients worry about doing when they have lapses or relapses. So this strategy should be discussed before the quit date, not just after a lapse or a relapse occurs. Any smoking at all, particularly in the first 2 weeks of a quit attempt, significantly increases those relapse rates. Additionally, most relapse occurs within the first 3 months of abstinence. After 1 year, the risk for relapse decreases more and more each year. Excuse me. So people who are preparing to stop their tobacco use should remove tobacco and tobacco-related products from their environment. And identifying high-risk situations that might trigger a relapse helps the individual prepare and plan for how they're going to handle that when it arises. Individuals may also make changes in their environment to avoid being triggered. As people engage in tobacco-free behaviors or other behaviors that facilitate their well-being, their experience can serve to really increase their confidence that they can live a tobacco-free life. Pardon me, my voice is giving out after a cold I had last week. But we're getting there, so I'm going to do it. Adherence interventions that involve multiple components are best, but providers should take care not to overcomplicate the treatment plan for the client, as we were talking about earlier. Look for strategies that already align with the client's treatment plan. And this slide lists a few things that sites can consider in some cases, and I'll just highlight a few of these as examples of how NRT adherence can be attached to other protocols that may already be in place. So if a client already has a case manager, for example, or an aide that goes to the client's home for the purpose of monitoring, let's say, medication for schizophrenia, then have that individual observe the NRT medications as well. Or if a client is already in family treatment, be sure to communicate to the family therapist that the client could use some additional assistance with NRT adherence, if that is the case. And when training behavioral health providers, suggest that relapse plans are a part of broader treatment plans. So we've talked about how providers want to avoid making treatment plans more complicated than is necessary. Medication adherence protocols do complicate the treatment plan somewhat for the client, and they do add additional oversight tasks to the clinic or the clinician. So it's not necessarily a good idea to add medication adherence protocols for everyone, assuming that everybody will fail to comply. What we want to do is try to identify those for whom medication adherence might be an issue. So to summarize these 3 bullets in the top banner, a higher risk for medication noncompliance would be people who take more medications already, and those who need them. So in other words, people who have comorbid medical conditions perhaps, or behavioral health conditions. And then higher risk for medication noncompliance. Also, NRT simply isn't as, well, I'm sorry, I lost my place. NRT is not as good as cigarettes in delivering nicotine, as we know. So higher dependence means that cravings simply aren't addressed as well. So that's the last bullet on that top banner, is simply that people with a higher dependence to nicotine are more likely to have a problem with medication adherence, simply because the medication is more likely to be underdosed and less likely to work well. Whether a person is identified as higher risk or not, though, clinicians should still be on the lookout for clients that might not be taking their medications in the most effective way, so that they can address those issues. These kinds of signs are in the second banner here. So things like missing appointments, missing refills, those are just clues that there may be some medication non-adherence going on. And then finally, clinicians should be simply asking clients about their use and their experiences to determine if using medication adherence protocols are even necessary. So how do they feel on the medication? Are they having trouble remembering? Are they able to use it as they have been instructed? So just using this exploration time to determine what precisely is this patient's barrier, if any, to compliance, and then try to adjust their plan accordingly. And that is all of the information that I have to present to you today. So I'm going to turn this back over to Jim, and I think he's going to help with a question and answer session at this point. So thanks for bearing with me with my coffee voice here at the last bit. Jim, are you there?
Yes, I am here, and I'm just struggling trying to unmute myself. So,
well, you were successful.
Hold on just a second while I get my place here. All right, so as always, we like to close by sending everybody to the National Behavioral Health Network for Tobacco and Cancer Control. They host and hold a whole bunch of webinars throughout the year. They provide a bunch of resources, especially those that deal specifically at the intersection of those people in the behavioral health population, also those, and then the intersection of the behavioral health population with tobacco and potentially cancer as well. So a lot of advice on various screening procedures and best practices in terms of both of sort of systemic approaches to this really complicated area, but also sort of just generally across each of these 3 different categories. So I know they have a couple coming up on, for example, tobacco and opioid treatment together. So I'll be on the lookout for those. And then at this point, I'm just going to open it up for questions. And just as I mentioned at the beginning, you can chat in a question. You can chat that into Dr. Garver-Apgar or myself, and we will get that answered. Or you can use the raise your hand function. Once we see that you've raised your hand, we'll unmute your line and you can just ask your question directly. Or you can use the Q&A box, as some of you have already done, to alert us to this problematic slide sharing situation. And again, apologies on that technical difficulty. We'll figure out what's going on there and we won't run into it in the future. So while we're waiting, and sort of in reference to the technical difficulties we were having, I do want everybody to know that we will be providing a video link, or a link to the video recording version of this webinar. That'll be up on our YouTube channel. You can share that link as widely as you think it needs to be shared. We will also be sharing a PDF of the slide deck, so if you did miss some slides, that'd be a good way to just sort of very quickly review what was being shown when you couldn't see anything. I'll also add, while we're still waiting for questions to come in, an interesting side note on the slide that Christine shared on the effects of smoking on various medications, is that tobacco smoke actually also interferes with the body's ability to absorb or properly use or metabolize various nutrients. And just as an example of that, it's been estimated that smokers, and this is again smokers specifically, require about 1/3 more vitamin C than non-smokers do, because the body just can't break it down appropriately.
That's interesting, Jim. That makes sense.
Okay, well, seeing no questions roll in, we will go ahead and sign off, and we'll all talk together shortly. We'll be on the lookout for another, we have another webinar coming up in either April or May, and you should be able to join us for that as well. Thank you.
Thanks, Jim. Thanks, all.